I'll now move over to the molecular tumor board. I think some of the questions were already taken by Vivek. First of all, I think Twitter is buzzing. As I just texted, Twitter is buzzing with appreciation for this talk. And I'm not going to keep two brilliant people apart. So we have Dr. Ullas Batra moderating the last molecular tumor board of this evening, and I really kept a powerhouse at the end. So he's the co-director of Department of Medical Oncology, Chief of Thoracic Medical Oncology at Rajiv Gandhi Cancer Institute and Research Center in New Delhi. And Ullas is going to be moderating a great panel. Vivek Subbiah, Dr. Balazs Halmos, Dr. Paul Hoffman, Dr. Jay Mehta, and Dr. Amit Rautan, and obviously Dr. Nitesh Rohatgi. And so we are going to see all the different sides, nuances of the discussions happening around Ullas's case. And I wouldn't keep the audience away from such a wonderful panel. With that, we will be ending our session. And so let's see the final real show of the evening. Back to you, Ullas. Please take on.
Okay, thank you. And I'm sure I'm going to be a dampener. After excellent talk by Dr. Subbiah, nothing is going to beat that. So I'm sorry, Dr. Sevanti, you have kept the wrong person in the end. You should have ended with Dr. Subbiah. And can I also request you to be a part of the panel? It's always fun to have you and your presence and your views in that. But we are already late. It's already, we were talking about personalized medicine, and I'm talking about the personalized panel discussion today, because all my best laid plans of 40-minute panels are going to go awry because we only have, I think, 20-25 minutes. So this is not exactly a molecular tumor board. This is more of a discussion amongst friends about what we exactly do and what are the questions that we face almost every day in our clinical practice. And my first reactions when I ever present the conundrums in treating non-small cell lung cancer is, this is where we have come back from. This is the plateau trial with a median OS of 7.9 months, 1 year survival rate of 33%. This was then, and this is now with a 5-year survival of 32% in lung cancer. So between then and now, and I was looking at, the definition of Gen X. Gen X is those sort of people who were born between 1965 and 1979-80. Probably most of us are in that age group, right, which have seen the evolution which is happening in the field of thoracic oncology, at least. I'm sure Sevanti doesn't belong to that. Sevanti is in Gen Z right now, or Gen Z2 or whatever it is, Except for Sevanti, everybody's in Gen X.
She's a millennial.
She's a millennial, yes. So also, somewhere between playing snakes in our parents' Nokia or our own Nokia phone and our children playing Candy Crush and Subway Surf in all smartphones, we grew up, as grew the lung cancer treatment actually. And this is what I think, what I will give it to all the researchers of the great talks that I have listened before. This is one of my favorite, This is a quote by Steve Jobs which says the people, ones who are crazy enough to think that they can change the world are the ones that actually do. And I'm sure Dr. Subbiah is going to agree with me on that.
Absolutely. Right there with you. Absolutely. Absolutely.
Yeah. Okay.
I get this always. Okay, I'm sure you all do. I'm sure you all do. Absolutely. Yeah.
I'm just a moderator. All the panelists are the big people in India who's actually doing all these things. Okay. So let's start this. A classical case of a female who had some cough and breathlessness for 2 months. A PET scan done, show the stage 4 lung cancer. Biopsy from the lung mass show adenocarcinoma. So I kept some discussion in the beginning about, how do you approach this case? NCCN says 8 category of testing should actually be done. Are we actually doing it? So I will actually start with this. Let me start with Nitesh. Do you really think, Dr. Vivek Subbiah very clearly said, for him, anybody who works in into the clinic, walks out with an NGS report. That's the message I could take it out from them. He said genomics is the key towards the end of his talk. What is your opinion, Nitesh? And how many in the last 100 patients of lung cancer, how many have got NGS upfront in your lab, in your clinic?
So you're asking two questions: how many do it, and how many I would want to do it? I would want to do all, for all the reasons, for the basket trial kind of approach which was shown. We really can't predict who's going to get what. How many do we do? I think it's a very different question, because we have to not only judge the affordability of the test, but the affordability of the treatment. And I think there it drops by less than 50%. But I would like to do all. Wherever affordability is not the question, I certainly start with NGS in lung, adeno, especially female, especially non-smokers.
Okay.
So can I have a short interruption?
Sure.
It depends, of course, of the country where you are going to work. I mean, it depends of the reimbursement that you can get. Of course, it's totally different if you are working in US, in India, in France, in Europe. I will say, of course, NGS is fantastic, but it depends also of the money that you can get for having the results first.
True that.
And
I'm going to come.
This is the first point. The second point, we have also some trendy, I will say, orientation to say that plasma first, not doing biopsy tissue first. So I would like to know your impression about that.
I am going to come to that, sir. I'm going
You know
to
what I
come to
mean?
that.
You know what I mean?
I definitely
of course,
agree with you.
NGS is fantastic, but it depends also of what you can get when you have in your pocket. Okay.
True that. True that. So so Nitesh said, coming back to the panel, I totally agree with you. I'm going to discuss more about our tissue NGS panels and our liquid biopsy NGS panels and what are the problems with NGS. Nitesh said around 50% of your people will upfront get NGS. Is that right, Nitesh? A ballpark figure?
Yeah.
Okay. Dr. Amit from Bangalore.
Thanks, Ulas. I'd first like to thank Sevanti for having me in this excellent meeting. It's been wonderful listening to all these talks. Learning experience has been wonderful.
Amit, before you answer this question, can I ask you, how do you look so fresh at 10 o'clock in the night?
Oh,
only you and Sevanti are buzzing with excitement and confidence. Sevanti, I can't ask all these things. How do you manage to stay so fresh?
So the lectures woke me up.
Okay.
Last to ask this question at 10 p.m.
Okay, Amit, go on.
So Ulas, one thing I would say, so we talk of personalized medicine, but I think the first step is personalization of biomarker testing.
Okay.
So it's something you can't uniformly say. You can want for everyone, but you can't get it for everyone. There are different situations where your patients are very symptomatic. You want a very quick answer. We still send off a quick EGFR Alcross, get the report in 3 days, so we can start off that direction. If we get it negative, we send it for NGS. And yes, if patients can afford everything, tissue is not an issue. We definitely send out the NGS. We also send out blood-based NGS. So I personally feel it's personalization of biomarker testing. I would say it is not one approach for everyone.
Okay, but Amit, very politically right, a correct answer you have given me. But just tell me, out of your last 100 patients, how many have you got an NGS done for?
So I would say 75%.
Wow, that's a fantastic figure. Dr. Balaz, I hope I am pronouncing you right. So what is your ballpark figure in US? What would you say? NGS for everyone, and out of last 100 people, how many people have you got NGS done?
In reality, in a way, all roads lead to NGS, but still there's practicalities, sometimes limitations of tissue, patient being just too ill for any treatment. There's some aspects that ultimately reduce that number. I might say that probably in the United States with metastatic non-small cell lung cancer, 70 to 80% of the patients will get some form of NGS, and that will include either a ctDNA test, which is becoming more and more commonly used, or tissue-based. Rarely both are done. I don't think it's routine yet, and there's financial constraints in a way. We cannot waste resources on a certain level. if it's not justified. But I would say probably 70-80% of the patients will have a multi-panel NGS type testing.
Oh, that's fantastic. Actually, I mean, 75%, 80% is what Amit Rotan said, and 50% is what Nitesh said. So, Dr. Sevanti, I'll come to you. So, what do you think are the constraints which are there for widespread usage of first-line NGS in India? I mean, let's talk about India right now, since we all are practicing over here.
So I think economic constraint is one of the biggest constraint, but I just wrote a commentary on the NINE tool, and I realized that even the testing methods are difficult. And how many times do we pass the message on to the radiologist, to the interventional radiologist, to the patient, to the pathologist? And so there has to be a synchronous way of conveying the message to the entire team, and that has to be made into an SOP. Until that happens, there are going to be lapses between what is biopsied and what you need, and what testing is supposed to be done, and what happens with the patient. So I think there are several limitations, amongst which the accuracy of retrieving biopsy is also one of the biggest limitations.
Okay, let me come to a pathologist with this. Dr. Jay Mehta, I mean, I'm sure you guys are doing a lot of NGS right now. How many times does the sample is not sufficient? How many times are you not sure? I mean, what are the factors that the oncologist or the radiologist can do to get the yield better?
So, Ulas, for people who regularly send it to us, what we have started doing is we just allocate the samples into different tubes. So the biopsy comes in, 4 kind of containers. So we make one for the HLE, that's the primary path diagnosis. Others we use it for PDL1 and Alcross, and the 4th one goes for the molecular testing. So tissue is really not that much of an issue now if you kind of, liaised with your interventional radiologist. The problem is in providing the fixative to them, because sometimes you have the tissue, it's just not good enough. The DNA is not amplifiable in it. So you have all the things in the world, all the tools, but you can't get it going. So these are the factors that need to be addressed.
So, okay, Dr. Subbiah, can you give us some tips about how can we make our systems better? I know you can't do anything about the cost. Is there something in the fixative or the technical errors that you would like to pass on the message to us?
Hey, the thing is that one thing is, I always say this quote, when India sent the rover to Mars, it cost less than the movie Gravity.
Yes, it
did. $70 million. I think India can be the model for the world. All right. So I think it can, if India wants to do it, if there is a will, they can bring down NGS cost to $1. So everyone can get it. You know what I mean? I think India, if there is a will, I think there is a way. I think India can really make it happen. It can really make it cost effective. So I think, I think that should be our ideal goal is, every patient should be able to get it. I think India can definitely make it.
Can we send our specimens to India as well?
Absolutely. I think, I challenge Mani and, Sevanti and the group and everyone in India. I think it's a challenge to make NGS testing, a comprehensive NGS testing, $1, and we won't be having this debate.
I don't think that day is far enough. 2009, it was $1,000 here, and now I see it's so frugal. So I don't think, I believe in that. I believe in what you say.
So Dr. Jay Mehta, so I'm going to pay you, okay, I'm going to pay you $10. I'm a nice person. I'm not that frugal. Tell me, what is it that, why can't we come to $1? Let's do for that. Dr. J.
Well, no, it's question of economy of scale. More you can batch up the samples, obviously the cost goes down. $1, yes. I mean, that's something that you should achieve too. It's difficult because the one thing that, we need to understand is all these reagents and stuff come from overseas. So there's obviously a cost impact, there's a custom duty impact to it. We are far away where we can start making all these reagents and the equipment locally made. So we could reach there. It's not going to be tomorrow, but yeah, in the near future, yes.
No, but we can start paying you $1 from now onwards. You can reach it later. Okay.
Because you can start, I'll start the piggy bank. Yeah, we'll give you the reports later on.
Okay, sure.
Some things that I want to share with you, because I am a pathologist and I'm doing also molecular biology here in my lab. I mean, the major issue in NGS is when you get results, of course, but negative results. And you need to know why you have negative results. It's just because sometimes you have bad samples at the beginning. So the go-no-go to do NGS depends of the clinical pathologist first. If you have just 5% of tumor cells on your broken biopsy, I mean, the major issue, okay, you are looking and you are asking for NGS, you are very happy, you have negative results, etc., etc. But it's just because you have a bad samples at the beginning. So the major issue is to have a good partnership between the clinical and the molecular pathologies first. Okay?
Okay, fantastic. Great point taken. I'll come. You also spoke about liquid biopsy in non-small cell lung cancer. I'll go to Dr. Balas first. How many specimen? I hope I'm pronouncing your name right. I get a feeling I'm not.
That's okay.
Okay. Okay.
Like Balaji.
Balaji. Okay. The one more new thing which I learned today. So liquid biopsy. What percentage of your de novo non-small cell lung cancer patients get a liquid biopsy?
Well, instead of percentage, let me just say that ctDNA is fully validated by now for upfront, molecular testing. So we use it more and more in that particular context and also in the acquired resistance setting. So it has two fully validated uses. We use it more and more commonly. Just to answer your question, maybe upfront we use it about 50% of the time.
Okay.
Acquired resistance practically 100% of the time.
Sure.
Now, we'll see this used to be expanded drastically as the MRD assays will be developed, and there will be more and more utilization of ctDNA in screening detection settings as well. But currently, it's already a transformational event.
So, thank you. Dr. Sevanti, do you think tissue, you still will want to go for tissue, or you're okay with liquid?
Sometimes we have to do with liquid, Ulas. I would like to get tissue, but there are times when that story that I said happens and you're not able to get tissue. That's why actually more recently I draw blood as well.
Sevanti, ideally, would you like to get both or
I
either?
do get both. That's exactly what I was saying, that I do get both, because I'm not sure the tissue that gets retrieved, whether it comes back as necrotic and stuff. So if there is a female non-smoker where I'm really thinking, or even a male non-smoker where I'm really thinking driver mutation, I would get tissue and blood at the same time before subjecting the patient to anything.
I totally agree. At baseline, how can you get the PD-L1 evaluation on liquid biopsy? I mean, how to deal with immunotherapy versus targeted therapy if you have just liquid biopsy?
Absolutely, you're totally correct. It's just the typical patient where you're really thinking driver mutation, and we see that in Asia a lot. That's a patient where you absolutely want blood also before you give anything to the patient.
Sure.
So, Nitesh, your comments on this, and then Dr. Amit Ratan.
I think it's each one for themselves. If I had all the money in the world with a patient, I would do both.
Okay. But what do you do?
You
have all the money in the world. I'm talking about your patient.
I've done both in only one patient, which Amit and I share or shared. We don't share anymore. But I typically do solid if I can.
Amit, what is your take on this?
I think my practice has changed a lot in the last 1.5 years or so. So I'm sending out both for quite some patients, but I can tell you, I do a limited NGS panel. It's basically the lung cancer NGS panel, even on the blood. So we've identified some labs who just give us a limited panel, and we just send out both at diagnosis.
Okay. Okay, let's just continue with the case. Our patient has got EGFR-ALK cross negative. We underwent a single biomarker testing. She's a ECOG PS1. Her PDL1 is 70%, 22C3. So this is something which we have discussed many a times in our molecular tumor boards. Actually, your choice of treatment now. My simple question is: would you ask for a solid panel? Would you ask for a broad panel NGS before you give this patient a immunotherapy-based treatment?
So good question. But what BRAF and NTRACT evaluation in this patient? BRAF and NTRACT was negative too?
So I will just come back to you. The typical practice in India is to do EGFR-ALK cross as a first basis of investigation, because we have 35% of EGFR, we have 10% of ALK, and ROS is 2%. Very few centers actually do a broad panel NGS.
Okay.
So right now, knowing that only 3, because we had this discussion with a couple of, I think Dr. Solange Peters and Tony Mock had come, and they said that they would not actually ask for a broad panel NGS. And in India, we have had a huge debate about this particular point. So your views. I think I'll start with you, and then Dr. Balash, and then Dr. Vivek.
I mean, it depends, of course, of RET fusion, MET mutation, BRAF, NTRAC fusion. I mean, my choice of treatment will depend of all this kind of
what you're saying is you would want a broad panel NGS before you start a patient on a immunotherapy. Dr. Balash, your point.
First of all, Ulas, your Hungarian pronunciation drastically improved. So
you will slowly get $1 NGS also, don't worry.
So addressing your question, this is where, are you a purist or are you a realist in a way? And where I've come down to is that I at least want to have a ctDNA test back on such a patient before starting treatment. The problem with tissue-based NGS is that it takes such a long time. And for example, here in the Bronx, many of our patients are very heavy smokers, elderly, and are critically sick. So to make them wait for the 0.1% chance of an NTRAC or, a RET alteration, that doesn't make practical sense. I think I would hurt them more than I would help them more. So our setup is EGFR, ALK, and ROS, and at least ctDNA negative for actionable alterations before adding immunotherapy. That being said, if it's a very young non-smoker, I might make sure that the tissue NGS is back as well if the ctDNA is not informative.
Okay, Dr. Vivek?
Yes, completely agree with what has been said. And exactly, I think if the patient is stable enough, I think we can wait. If the patient is too sick, we need to start the patient with some treatment quickly, and go ahead with the case.
Okay, so here is it. The patient in India, you can take a second opinion very, very easily. So the patient took a second opinion, and this patient basically had a KIF5B RET fusion, and there is where we come down to RET now. So let me bring on my pathologist now, Dr. Jay Mehta. The first thing in lung cancer now is you have to know what exactly IHC, FISH, PCR, DNA, RNA is. For every gene, it is so different. Why can't pathologists make life simple for us? Why can't you just tell us which test to use? So what would you do for red gene rearrangement in non-small cell lung cancer?
For population, I always get boxed over by medical oncologists everywhere. Tell me, when are you guys going to give pembrolizumab for $10? That day, I'll give you the NGS for $1 that day.
You thought of this answer. Okay.
No, I never get a chance to rebut, so this time I get the chance. No, I understand what you're talking about gene, so it varies upon what you're looking for. So if it's amplification, perhaps you can look at IHC model, say for something like HER2 in breast cancer. Doesn't hold true for lung because you're looking for a kind of a point mutation that doesn't exist in this case.
Okay.
As far as
what would you do for RET, Dr. J? I mean, since we're running out of time.
RET, we can do FISH or RT-PCR, but I think NGS and particularly RNA sequencing would be the preferred mode of treatment.
So I think I'm going to go to Dr. Vivek Subbiah, the man himself. Dr. Vivek, just let us know, you spoke a lot, you spoke fantastically well. I'm in awe of your talk. How would you diagnose? Let's go take a step back. Let's forget the selpercatinibs and palcetinibs. How would you diagnose a RET for all the young colleagues that we have? You are muted, Dr. Vivek.
Yes, panel. I think in this case, I would do a comprehensive NGS panel. I think, in lung cancer, especially right now, we have like 9 targets that are approved. And I think for RET specifically, we need to do a comprehensive NGS panel that is RNA panel at best, if not a DNA panel to see the partner fusions. Because I think, you can see, you can talk to, how sensitive and specific, the FISH, RT-PCR, and IHC is not useful for it at all completely. So I would definitely go for an NGS, a comprehensive NGS panel here.
So according to, so whatever, I think this is what the pros and cons over here.
So can I say something or not?
Sure.
I mean, yeah, thank you very much. I think the guideline now to do RNA NGS, of course, but it depends also of the quality of the quantity of the RNA. If you have a bad quality of RNA and a low level of RNA sequencing is quite difficult. So of course, the first goal is to do RNA NGS. Is the gold standard for looking for rate rearrangement, of course. And you know that you have some competitor right now. I think you know BioCartis from Europe. BioCartis develops now some IDELA system with different panel for looking for fusion and integrating also rate. So this is just my point of view. Of course, it's very important to do RNA NGS, but it depends of the quality and the quantity of the RNA.
Okay, I think Dr. Sobhaiya needs to go. That's okay. Is there a coordinate for testing a rate fusion in non-small cell lung cancer? Dr. Balash, if you can come back, this was the ESMO guidelines that I took.
Yeah, we have relied purely on NGS. We have not found it useful to incorporate any other type of single gene testing, going beyond EGFR and RAS. There's just too much effort, you waste too much tissue. So it's liquid or tissue-based NGS. RNA has an advantage. This is exactly where it has an advantage, fusion detection. RET a little bit less so than NTRK and energy, but NTRK and energy fusions are very difficult to detect on DNA. So RNA sequencing has an advantage.
So for you, it has to be an RNA-based NGS to detect the fusions. Is that what I can understand?
Ideally, if you run ctDNA, I can ask for RNA, but there's no RNA-based ctDNA test. So, but if you have the right patient, you need to dig a little bit further, and that's where the RNA-based panels are appropriate.
Okay, I think I'm going to, because we are running a lot short of time. So Nitish and Dr. Amit, the third question for you: immunotherapy in rate rearranged non-small cell lung cancer.
Not
your
for
take
me.
on that? Not
For
you.
me.
So this again brings
only
out
BRAF.
Only for BRAF and maybe KRAS.
Yeah, I'm talking about targetable agents at the moment. You could say 2021 may saw a new target. He had not exposed to that, but
okay.
Yeah.
Fair enough. Amit, Dr.
Fully
Amit?
Agreed with Nitish. Fully.
So you have to, right? Who can dare not to this thing? So this is what shows the pemetrexed may have slightly bit more sensitivity towards rate rearranged non-small cell cancer. The multi-kinase inhibitor, initially I have given lenvatinib and alectinib to our patients when selpercatinib and pralsetinib was not available, but not really very effective. This is very important. In the immunotarget registry, again, there were more bluish dark that was progressive disease than there were partial responses or stable disease. So definitely in a rate rearranged non-small cell lung cancer, immunotherapy is not for you.
I will say just one thing. I know very well Julien Mazière, one of the co-investigator. Take care about these results. It's we do not have a lot of inclusion of patients in first line in this result. It's second line of treatment. Okay? So take care about that.
Here is was Dr. Balash. So RET inhibitor, first line or second line?
Yeah.
Well, usually, as much as we've been able to define them up front, I think there's a bit of a sense that patients do better, frontline, therapy with the targeted drug. So as much as possible, we would like to use them frontline. Now here, of course, KRAS will be an exception because the G12C inhibitors will be approved or are approved second line, and the activity is not that great. Maybe 35% response rate. So those we want to reserve second line. But the rest of the actionable, markers, targeted therapy tends to be given frontline.
And have you used them a lot, Dr. Balash? In India, I don't think we have much experience. So what's your experience?
Well, we've used them, of course, occasionally. These are not very common, targets to find, but these drugs are very well tolerated in general and fantastic when it comes to their activity. So finding these patients is very important, and they add up. Is the ret and the NTRK and the energy. They add up. Being ultimately 20% of your patients with EGFR and ALK, and of course the PD-L1 high category we're going to find as well to limit the need for upfront chemotherapy for many of our patients and optimize outcomes.
Okay, I think Dr. Sevanti asked a question in the chat box earlier, which was about a patient who has got a high PD-L1, a red rearranged tumor, and a high TMB. What would you do, Dr. Balash? I can take it for, if you can ask this.
Well, that's definitely not a common scenario. Most of the fusion positive patients are non-smokers with a very low tumor mutation burden. So first time I kind of, speak with the molecular pathology lab to make sure that, the information is correct. If it's correct, the patient has, for whatever reason, MSI high or something of that nature. It's not inappropriate, to give the patient a trial of immunotherapy. But it doesn't seem to meet the typical description of these patients being very low mutation burdens. I would ask some questions first.
Okay.
Last, but can I make a comment also?
Sure.
I think one of the problems is, and there was a biology paper on this, that when you have a target available and you do multiple lines of treatment, the TMB goes up. That's not really saying that this is a unstable MSI and therefore TMB is high, therefore immunotherapy will work. So I'd be very careful in the high TMB group in a patient who's got a target available and multiple lines of therapy gone in already.
So let me come to Dr. Hoffman on this. Dr. Hoffman, what's your opinion about the TMB, the T word? I mean, most of us, it comes yings and yangs and goes. So what's your take on that?
About what?
About the tumor mutation burden, TMB.
Okay, TMB. No, I mean, right now TMB. I have to say that there is a mystic clinical trial. It's positive. It's published 1 month ago in GTO. Okay, but I would say I will be not afraid about the TMB. But right now, I think it's a little. We need to confirm the TMB as the predictive biomarkers in general, because definitively you are perfectly right. It's a fantastic question. We have harmonization to do according to the different devices, etc., etc. I think TMB is a good predictive biomarker, but it's quite difficult to control. It's not the same that PD-L1 immunohistochemistry. It's very, very difficult to control. Maybe it will be useful, but right now we say by 2021, it's very difficult to give a clear-cut answer. Sorry about that.
Dr. Balash, your final comments on TMB. I saw you almost trying to make a comment at that time.
I think TMB remains an intriguing biomarker. It hasn't been validated on the level that we could use it, in terms of treatment selection, but it helps refine your choices. I think, so if it's available, I definitely look at it. For example, for a PD-L1 high patient, seeing a high TMB gives you a very high level of comfort that that patient could do really well on single agent immunotherapy. Same patient, maybe a non-smoker with low TMB, you will start questioning, your choice of single agent IO. So I do find it useful. I'm not as sold on it as Dr. Kurzrock is, but I'm also not an opponent of it.
Okay, that's nice. That was my last slide. It's an exciting time to be a thoracic medical oncologist. Immunotherapies and targeted therapies have been a game changer. I think we have to move towards broad-based NGS, whether it's $1 or $10 or $20. We need to go to NGS sooner than later. In my opinion, challenges for the next decade include finding out the resistance mechanism, whether acquired or primary, to TKIs and immunotherapy. And with this, I think we are going to go to the end. And for all everyone across, please stay safe. This too shall pass, and I'm talking of COVID, not my moderation. My moderation might pass like a kidney stone, but it has passed over there. With this, thank you. And this is my favorite slide. Lung cancer deserves a cure or a long-term control too. Thank you. Thank you to all my panelists and Sevanti for the invite. Thank you.
Thank you so much. Thank you so much.
Thank you, Lars, for the wonderful moderation and such an animated discussion and such an apt finish to the symposium. Love it. totally, and love the participation. And thank you all for staying this late. We have over 350 participants even now as we are talking at this time of the hour. It's 10:30 p.m. in India, but this meeting is global. So really grateful to all the faculty who are here, speakers, moderators, panelists. Thank you, Vivek, for your talk. Thank you, Ullas, for the moderation. Thank you, Nitesh, for hosting, and all the panelists for this last MTB. I will take just half a second to thank Balaj and Paul for their wonderful contribution, Amit and Jay for staying back till 10:30 p.m. and contributing on the panel. I would also like to take half a second to thank my genomic colleagues who have joined in the Impact India MTB group. I see Dr. Raja, sir being here, Nirmal, Umar, all of you all, thank you from my heart for making this a success. Or my pharmaceutical colleagues who have really spread the word out. Thank you. I've actually WhatsApped them over the last month and asked them to join in, and many of them have gotten back saying what a wonderful meeting, what an academic treat. I thank my Kokilaben Hospital team for a wonderful support that they've given me. My students are actually the Kokilaben team, the Iylon team. Students are right here in the next room, 10:30 p.m. They're all with me, supporting me. And back to the Iylon team, Dr. Mani and Dr. Padmaja to finish the meeting. Thank you.
So
Thank
we
you
are
so
at the
much.
T word, Dr. Batra, but this time with a capital T. So on behalf of Iylon, I wish to thank you all of you for making this symposium an incredible success. At Iylon, our aim is to deliver exceptional service with empathy, sensitivity, and speed. And I cannot say that enough, the empathy word here. We encourage all you clinicians in our audience to sign up as an Iylon physician if you haven't done so already, so that when one of your patients is in need, a second opinion is just a click away, because you can just go to the app and do that very quickly once you're registered as their clinician. And thanks once again to our keynote speakers, our panelists, our involved audience. And I would like to thank Sevanthi for her dedication and for pulling innumerable all-nighters, I know this for a fact, to make this event such a resounding success. And of course to Mani for his guidance, support, reach, and for making this a really star-studded event that it is today. Thank you, Mani. Thank you, Sevanthi. Thank you, everyone. And especially thanks to all those Iylon team members in the background, in that other room,
Great.
who
Thank
took
you.
care
Thank
of the
you.
precise details.
Thank
So
you.
thank you all.
Thank you, Padmaja. Thank you again for all of you. At this late hour, particularly in India, I have no idea who from other parts of the world. The goal is, the border is broken now, so therefore we should use this as an opportunity to really penetrate and help people beyond the border. That's the goal. So I just take a few seconds, I won't take a lot of time. I know you all want to get your dinner, go to bed, whatnot. Sorry, I know you stayed this long. Just take 2 seconds with me, or a minute with me. So there are people from the Iylon's team that really worked very hard. This is Chetan, Shambhavi, and there are, Sevanthi found some amazing folks who really put together this entire program seamlessly. There's Nimesh and Praveen. And there is, there are people who build a website for us. It's the Bisham and Sachin. They're really remarkable. Thank you, guys. And our special thanks to our advisors and the keynote speakers, Dr. Massimo Cristofanelli, Dr. A. Kruzrak, and Dr. Vivek Subbiah. Thank you, guys. Thank you so much for making your valuable time and educating us, entertaining us, and then it's really a feast, an intellectual feast. And then our moderators, Dr. T. Raja, Dr. Nirmal Rao, Dr. Ullas Batra, thank you really for trying to keep it on time, because it's very hard. And then giving really the insight about the whole program. And our panelists, Dr. Paul Hoffman and Dr. Balaz Halmos, they both not only panelists, they are also advisors. So thank you both for making time and staying this late. And then, of course, our panelists, Dr. Kumar Prabhash, Dr. Umit Risal from Turkey, Dr. Ullas Batra, Dr. Amit Roitan, Dr. Nitesh Rohati, Dr. Jay Mehta, Dr. Sudeep Gupta, Dr. Shahina Dawood, Dr. Amit Verma, and Dr. Sendil Rajappa. And then most importantly,
we say thank you, Mani. Okay, thank you, Mani.
Thank you. And then special thanks to the audience. The thing is, we want to make sure it's highly interactive, and you all interacted well. And again, the reason why we are doing this is to educate the public, educate those oncologists who are not familiar with this. You guys are the one who are in the panel. You are all experts in precision oncology, and the goal is to spread such a powerful medicine or the aspect to the people who are not aware about it. That's the goal. And that's where, it's very important to have such kind of an educational session and then bring in more clinicians and explain to them what is precision oncology and how it can save their patient. And you guys are passionate about it. I would strongly recommend, or I recommend all of you, if possible, please spread the news. We will have this symposium once every month on the first Friday of every month, so that we can keep spreading this, the knowledge, what we know about precision oncology to everyone. So all the audience, please tune in. We will have this meeting every month on the first Friday of each month. And then finally, I want to thank Padmaja. She also worked tirelessly to get this program organized and working with various teams. It's not an easy task to work to put together such a wonderful symposium. And of course, Seventy, as Padmaja said, worked tirelessly to get this symposium off the ground. And I have zero contribution. All the credit goes to Seventy. And then again, if you are a clinician, please kindly sign up. You will get more updates and participate in this MTB, more seminars and things like that. And then of course you are more than welcome to bring your patients through this portal to help them. And our mission, again, there's only one: help. And unfortunately, we cannot run it as a non-profit, because I wish I am rich. We would have done it just as a purely non-profit, but just because we cannot do it at this point, we are making it as a kind of paid service. Please sign up and ask your friends to sign up and bring your patients and help them. And with that, let's make this world cancer free. If not, at least make the people live without suffering, or help them to come out of the cancer as early as possible. Thank you all for your wonderful time and spending time with us in this evening. And with that, I thank you, everyone, and have a good evening, good morning, good afternoon, depending on where you are. Thank you.
Thank you so much, Mani. Thank you. Great job.
Thanks.
Great job.
Root, and thank you, Nimesh.
Yeah, fantastic.
Bye-bye.
Bye.